So hi everyone, welcome to my channel. I am Dr. Saurabh Dikshit and you can see behind me it's FMGE 2023. It's over. So a lot of students are relaxed, some are confused what will happen, what will not happen. So you must be wondering that why I have delayed this recording for 1 or 2 days. The reason is that it took some time for me to collect the question and I was not getting concrete questions from the market. So everyone was giving a lot of things, lot of inputs were there. So I've decided that okay, I'll take some time. So I've collected this question. So disclaimer for this session, I don't own this question. I have not made this question. I have recorded it as per the, you can say, the source from the market. So I've outsourced all these questions from the market and I would be quickly brushing through that. But before that, a synopsis. As we used to think FMG, now the FMG has changed. This time the paper was more GIT oriented and urology oriented. Normally what perception we have, do trauma, do burns and do this simple concepts of your general surgery, you will be through. But this time there were lot of questions through GIT. There were a lot of questions which were image based question and it was a mixed balance paper. It was a good quality paper and students having a good, you can say, academic background would have cleared it. So without wasting a lot of time, whatever has happened, let us revise this question. So those who are watching this, who are ex-FMG students now, they are also welcome. Those who think that they will not be able to make up, for them also, and NEET and Nexus, whatever, this is around the corner, so this will be a great revision for you also. So the first question that we take, I've aligned the image based question first. So a baby with excessive frothing and distress on day 2 of the life. So baby with excessive frothing with distress 2 on day of life, and what could be the reason for excessive drooling of saliva or frothing? It could be esophageal atresia. Normally for esophageal atresia, what do? We do a simple, the first line investigation is not a bronchoscopy or it's not a contrast esophagogram. The first line is standard is X-ray with feeding catheter. So X-ray with a feeding tube is what we do generally. So if you see this X-ray, the feeding tube is coiled. So one thing that you can see in this X-ray is the coiled feeding tube. So this coiled feeding tube indicates evidence of esophageal atresia. Now the second thing that you need to notice, the gas in the stomach. So if there is a gas in the stomach, that means there is a tracheobronchial, the tracheal and the esophageal connection. So this is esophageal atresia with TEF. So probably it's a type C now. So according to the answer, it's a type C. But however, this question was made very simple, whether it's atresia or atresia with a fistula. Remember students, merely fistula is not possible. It is very rare, it's an H type, so the image will be something different. So if this was the image, the answer is that it is atresia with a distal TEF. So it's a type C now. Next is what kind of instruments? Students, you can go to my playlist. I have before the exam uploaded a video on staplers in important instruments and I've shown actually live staplers. I have shown to you, I've shared the video. So what kind of stapler this is? This is a GI stapler. And what kind of GI? This is a GI stapler, linear. Why it is linear? Because of the shape. Now, why it is decided that it is cutting? So try to understand. Can you see a blade here? So this is a blade. Can you see this is a blade here? So those who still cannot see, so you can see there is a blade. So you can see the 2 rows of stapler pins with the blade. So this is a linear cutting. So we have a linear stapler and linear cutting. Linear cutting is this, linear stapler. Yeah, it's a T-shaped stapler, you must have seen. And if you have not seen, go to my video and check it out. So the answer for this is A. Now just see again a very simple question. A patient of, you can say, presenting to you with pain over the groin and a CT was done. So generally we do NCCT. Now here the contrast CT has been done and you can see the stone at the level of mid-ureter. So stone at the level of mid-ureter. And what is the ideal management for this? It is USL. It is not URS. It is USL, ureteroscopic lithotripsy. So we are going to take out the stone via ureteroscope. So the answer is USL. Now when it could have been PCNL? Now the question is, could it be a PCNL? Yes, if it would be a proximal stone. Remember, a proximal stone, normally many a times the ureteroscope tries to take out, it fails. So in that case, for proximal stones, we might do a push back What is this pushback? We push the stone back into the kidney. That is the time when you can actually do a PCNL. So it's not wrong. So those who are laughing that PCNL cannot be done, no, but not for this patient. It's not for the mid ureteric, only for the stones which are proximal to the renal pelvis. That is what is very, very, very important. So answer for this is B. Next is again a topic of esophagus, a very, very simple, straightforward question. A 4-year baby with a foreign body injection. What is the next line of management? You can understand this is what coin is, and that is why we avoid giving coins to kids. So this is urgent bronchoscopy and removal, wait and watch, Helmix. What's it? It is upper GI endoscopy. So it is upper GI endoscopy or esophagoscopy. So whatever is esophagoscopy or upper GI endoscopy, many of the time this is the place where the stone is lodged at the this coin is lodged at the level of cricopharynx, cervical length of esophagus, so upper esophageal sphincter. If it is able to cross, then most of the time it is found in the stomach. Most of the time. So we go for upper GI endoscopy followed by removal. So option D is absolutely right for this. Next question. While doing endoscopy, now this is very important, while doing endoscopy, a depression was noted at the level of esophagus, 25 centimeter. Now 25 centimeter is a broncho-aortic constriction. Now this is what is very, very, very important. Now what it is actually the left bronchus. Arch of aorta 24 centimeter, 25-26 centimeter, it's the left bronchus. So probably the answer is left bronchus in this case now. Now which of the following? Now the image is synergistic gangrene at the level of you can say scrotum. So this is a Fournier's gangrene due to dual blood supply. The testicles are supplied directly from the testicular artery, which is actually coming from the main trunk, and then you have the scrotal skin supplied by the internal iliac in its branches, pudendal, and lot of things. So what is spared? I couldn't get the options because students couldn't recall it. So testis is spared. This is what we know, and that is what is the treatment for Fournier's gangrene. So diagnosis is Fournier's gangrene, and the treatment is debrided to an extent where the testicles are visible. So we call it shameless exposure of the testicles is the treatment. This is what is the management. Now this is what you see is PUD orange, discussed a lot of time, and what is the reason? It is nothing but due to the invasion of superficial dermal lymphatics by the tumor cells. Thus the subcutaneous edema doesn't get relieved, and there is swelling at this level and pitting at the level of the lymphatic channel. So what is the answer? Superficial lymphatics. It is the dermal lymphatics which is involved in this case. The next is a question, straightforward question from hernia. So a patient presenting to you with the groin swelling, with the swelling in the groin. So this is the swelling in the groin that you can see. What is the answer? Yes, this is an adult. So you will be going for herniorrhaphy. So it's basically you go for lap, you go for open, you go for Lichtenstein, whatever. But repair is very important of the myopectineal orifice of Rucho. So answer is, this is a case of hernia where we'll go for herniorrhaphy. There was one more question from hernia. I'll come to that. So this is a cleft lip. Now when we talk about cleft lip, we need to understand there are frontonasal process, and this is made up by nasolabial folds. So there are nasolabial folds which combine to form a frontonasal process, and then you have maxillary process on each side, and these are the palatine shelves. So basically palatine shelves are going to form the palate, secondary palate basically, and maxillary folds along with the frontonasal process, this is going to form the lip. So if you have a cupid lip, so this is a normal lip. If you have a lip like this, so hair lip defect, this will be only due to nasolabial folds. But in this case, this is a lateral, you can say unilateral cleft lip. So the answer is, it is because of the nasal process and the maxillary process. This was the recall. That is why I said, otherwise the answer could be non-fusion of frontonasal process with the maxillary process is the answer. So B, this is again very, very, very important. Then something on X-ray. This is a hyper repeat question every time you get to see. What is this idli-like sign? This is EDH. So I'm not going to waste a lot of time. This is EDH. A simple, straightforward question. This is very, 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 very simple. Very simple. Next is again a CT scan showing to you something. What is this? This is a simple image of horseshoe kidney. So horseshoe kidney, how do you align this? Just see, this is what is horseshoe kidney. I'm not going to waste a lot of time. There are a lot of people who have made a discussion elongated. This is recall, so I'm not going for that. So this is not ectopic kidney. This is horseshoe kidney. During the time of ascent, it generally gets lodged at the level of the aorta and the inferior vena cava. So this is a horseshoe kidney. Now try to understand, this is an image of aortic dissection. So this is an aorta, can you see, this is an image of aortic dissection. Students, before you do anything in this aorta with its dissection, the first thing is control hypertension. So control hypertension, else you lose the patient. So pulse and rhythm control, this is what we say, pulse and rhythm control to control of BP. So what should be the other thing? Yes, BP. And then you need to go for either trans-esophageal echocardiogram, or you can go for a CT or a CT angio. This is how you proceed. So if the patient is unstable, you take the patient to ICU, go for a TEE. If the patient is stable, go for a CT. On CT, if it is diagnostic of dissection, it's fine, else you need to go for a CT angio. In CT angio, if it is diagnostic, then it's fine. If it is not, then you need to rule out the things, what could be the other possibility. Now once the diagnosis is made either on TEE or on CT or on CT angiography, now you have to ask whether it is Stanford A or Stanford B. B has to be seen and evaluated whether it is involving the descending or no. So Stanford A or DeBakey 2, they are the one where the priority is to repair. But before that, every aortic dissection has to be managed with BP control medication. Next question is again on head and neck. I don't know, I couldn't get which of the following is not associated with suprarenal you can say mediastinal lymph node, superior mediastinal lymph node, or whatever it is. Some people said which of the following is not a superior mediastinal, presents to you with superior mediastinal mass. Answer is all of them can. All of them can. But the answer of exclusion here is lymphoma, not all patients will have. So there is a gray zone if this is the exact answer question, because I couldn't get the exact question. But if it is like which of the following is not, always not, lymphoma will always not be associated, because it could be lymphoma of anywhere, thymoma, thymus, thyroid, and parathyroid cancers they do. Next is homosexual male with a prolapsing mass with a foul smelling discharge. Answer is it could be suspicious of squamous cell cancer of the anus, and therefore you follow the Negro's regimen. Negro's regimen, where you go for chemotherapy, along with that radiotherapy. You have 34 grays to 45 grays over 15 sessions. Is that clear or no? And 4 cycles of, you can say, chemotherapy. This is what is efficacious as APR. So chemo radiation, or you can say a Negro's. Norman Negro was the first to decide this. So squamous cell cancer of the anus, yes, you go. Had it been the adeno cancer, then you would have gone for APR in this option. Now, best investigation for fistula, my favorite topic. I have recorded a lot of time on YouTube and taught a lot of time to all my students. Answer is MR fistulogram. We have a classification also, that is St. James classification. Without MR fistulogram, don't operate on the patient. Now, bilateral hydronephrosis is associated with, now try to understand, retrocaval ureter, ectopic ureter, both of them can be associated with hydronephrosis, but not bilateral. It is the bladder outlet obstruction or LUTS associated symptoms which can be associated. Posterior urethral wall is the best answer to be marked here, which is associated with bilateral hydronephrosis. Next is a question again from hernia. Which of the following pelvis will have a maximum risk? Answer is wide pelvis. Always remember, wider the aperture, more will be the entry, plus short. So wide and short gate, everyone can go. I try to understand, wide and short, everyone can go. So this is what is the answer for you. A narrow orifice is more difficult to traverse, but more incidence of strangulation is there. Next is patient with bone pain, abdominal groans, psychiatric notes. What are you waiting for? This is a hyperparathyroidism. So it is hyperparathyroidism. It could be due to adenoma, carcinoma, anything, or hyperplasia. The answer is cystamoeba SPECT scan or cystamoeba technetium dual isotope subtraction angiography, whatever you say. It's a cystamoeba which has to be there. So remember, cystamoeba SPECT scan or cystamoeba technetium 99 subtraction angiography, they are the 2 standard tests which are being done nowadays. We also have the 4D CT. 4D CT is again a very important. It's nothing rocket special. Image that you take and then you wait for a delayed image. Always remember, a tumor will have hypervascularity, so early uptake and maybe delayed, you can say, loss of contrast, and there we decide, okay, apart from the structural anomaly, this is where the perfusion gradient is also increased. So remember, this is what is the answer. Next is patient came post thyroidectomy and this is a papillary CA. Remember, papillary CA comes under DTC. What is DTC? Differentiated thyroid cancer. So papillary CA and follicular CA are the two cancers which are included. And remember, if it is more than 1 centimeter, you will always have to go for a thyroid scan. So this is where the thyroid scan comes. And remember, if there is uptake, then you will have to also go for radioactive iodine ablation. So all these options are wrong, not properly framed. The answer of exclusion is radioactive iodine scan. So that is what is thyroid scan. You can do thyroid scan, but you need to elevate the TSH level so that you can sensitize any residual tissue. Lot on discussion I have done in class, so this is a recall. It's beyond the beyond the time limit, so I'm not going for that. But remember, it's a scan that is mandatory until unless the tumor is less than 1 centimeter. Next is BRCA1, BRCA2. Remember, familial risk is important. Should be done for all except bilateral CA breast, yeah. Men with CA breast, yes. Ovarian and CA breast, because there is a familial angle. Now there is a trick here. So any female with familial risk of CA breast less than 50 years is what is the golden window. So not this. So C is not the place where you will go for a BRCA screening. This is a sporadic case. Next is again a question of oral cavity. So oral cancer, a patient presenting to you with a chronic history of tobacco consumption, and there is a white lesion. So what are you dealing with? You are dealing with leukoplakia. So what should be the next line? Excision biopsy. Excision biopsy is what is done, and this is what is leukoplakia or erythroplakia. The management is excision biopsy. Other things are, you can go for laser ablation or radiotherapy also, but this is what is the best answer here. Next is, which is common in all shock? It decrease in tissue perfusion. This is absolutely true. Increase in peripheral resistance, absolutely true. Why? The vessels constrict, resistance is increased, and this is where the blood is diverted to the vital organs. And third is decreased pulse pressure. This is also right. I couldn't get students the next option, so whatever would have been the correct answer. But this is what I got. So apologies for not getting the D option. But yeah, if you can suggest me in the options below. Comment section below. Which is not a component of Q-SOFA. Remember, Q-SOFA is a question which is repeated again. It is systolic BP less than 100. Remember, respiratory rate more than 22, and altered sensorium. So which is not altered sensorium? Is there, everything is there, but lactate is not. So option B is absolutely wrong. Nothing to worry. Which procedure has least recurrence of duodenal ulcer? Answer is truncal vagotomy. Truncal vagotomy is having maximum complication but maximum relief in terms of acid recurrence also, which is if the question would have been what is the treatment of choice, nowadays the highly selective vagotomy is the treatment of choice. So truncal vagotomy plus gastrojejunostomy is the gold standard in terms when you think about the acid level recurrence. So this was all about this year's FMG. I hope you enjoyed, and don't worry about the exams. Whatever have been the questions, whatever have been the circumstances, I know you people have done your best. Take rest, relax, talk to your friends, do whatever you have been actually willing to do apart from the studies for a few days. Leave everything on God. You have done your best. The luck has been logged. Just wait and enjoy this phase, students. This is not the time to worry, and learn from your mistakes. Don't commit them again. So do subscribe to my channel. Do share the solutions to your near and dear friends. Till then, bye-bye.